All right.
All right, you lost 5 seconds.
5 seconds. And begin. Okay, I'm going to talk about Bankart repair, glenohumeral instability with 10% bone loss. Here are my disclosures. So the information, what we know or assume is that this patient has 10% bone loss. We'll assume it's anterior instability and anterior glenoid bone loss. What we don't know are some really important factors: patient age, number of dislocations, humeral bone loss, the quality of their labrum and capsule, any physiological laxity, and information about their work, recreation, or sport. So we have to ask ourselves, is Bankart repair really the best surgical option in the presence of this amount of bone loss? How can we counsel this patient? And then finally, how do we maximize our technique to improve outcome? And so we're familiar with this article. We've discussed a little bit about on-track, off-track today. And they talk about bone loss and instability, and then they propose a treatment algorithm. And so here we have their group 1 patients, 25% glenoid defects, on-track Hill-Sachs, or maybe no Hill-Sachs lesion at all. Recommendation is Bankart repair. But I think we would all probably agree that 25% is probably too much. And so there have been other studies that have shown maybe 17, 15, or even 13% is a critical amount, but none that I've seen where it said 10% was too much for a Bankart repair. So the great thing about Bankart information is that if you look at the data, the short-term results are remarkably encouraging. What is not so encouraging are the longer-term results, and this paper has already been discussed a little bit, but this is arthroscopic Bankart versus Latarjet, and what we see at 6-year follow-up is fairly high instability, dislocations, but still, patients reasonably satisfied. And so when we look at the 10-year data, this is a meta-analysis out of Ireland, again, patients seem pretty happy, but still 31% recurrent instability, 16% dislocations, 17% revision. So we've talked a little bit about the ISIS score. Pascal quoted it. He didn't use it in his case, but he quoted it. And so what he found was that more than 6 points, high percentage of recurrence, consider a Latarjet. Now, Alessandro Castagna looked at this as well, 670 patients just to validate the ISIS, and what he found was that really, if you have fewer than 3 points, that's where your highest rate of success is. Any higher than that, you probably have a reasonable rate of a poorer outcome. So when I think about doing this, if we're going to choose this operation, let's do it right. The relevant information, visualization, tissue mobilization, number of anchors, where we place them, and then restoring tension, maybe less relevant, the type of anchors, rotator interval closure, and patient positioning. And so I'll just go through a very quick case. Here's a Bankart lesion, my view from the anterosuperior portal so I can prepare. You'll see on the left, there's the anterior inferior glenohumeral ligament. That's what I'm trying to retension. The labrum's important, but retensioning the ligament is critical. So we'll place our anchors. I do it not quite up on the face, but certainly not medial, right on the edge. You want to make sure that you pass this first suture well below your anchor so that you can get some superior shift and tensioning. If you're going to tie knots, try and tie them around the corner there, as I like to say. So either you can't see them or you'll minimize the risk that they'll slide around. Here's my second anchor. We're going to make sure we get a nice bumper. If you want to do a little bit of capsular tensioning, use the nip-tuck stitch as described by Dr. Snyder here, and so what we're doing is just taking a little bit more laxity out of that capsule. So when we're done, here I am translating that head. There should be a nice firm stop there so that we get some good restoration of tension. So in conclusion, I can say that Bankart repair can be successful. I would choose it for this patient as long as they have the right criteria. So, thank you.